Acute spinal cord injury has long been associated with finality and life-altering loss of ability. Until now, that perception has been largely correct. New hope has been found for spinal cord injury survivors in pioneering treatment that may leave that perception far in the past. Acute spinal cord injury leads the spinal cord to stretch or be displaced by bone fragments or disc material, potentially severing axons or damaging them beyond repair. That is not the only threat as a result of the acute injury. Local blood vessels may rupture, causing bleeding around the spinal cord and elevating pressure that may cause further damage. The injuries may manifest differently depending on the placement and degree of injury. The 15,000 Australians suffering from the effects of an acute spinal cord injury have very varied experiences. There are a growing number of treatment research areas, however, 4 are at the core of the prominent breakthroughs. Neuroprotection is the first and potentially most important area of research because further damage to neural cells can occur as a result of acute spinal cord injury. Issues arising from the acute injury, such as inflammation or swelling, pose a serious threat to adequate blood flow, proper nerve signal transmission, and cell survival. Other focuses target injury improvement via cell regeneration, cell replacement, and retraining of central nervous system circuits to redevelop function after acute spinal cord injury. In practice, treatment methods require crossover between a number of these research focuses. It is now established that neuroprotection can be achieved pharmacologically by expanding the use of the drug riluzole. Riluzole is usually used in neurodegenerative diseases, but has shown promise for the purpose of neuroprotection in patients who have experienced acute spinal cord injury. The drug preserves structural and functional integrity of neural cells by creating a block in a process that would originally lead to cell death. Where acute spinal cord injury causes rupture of blood vessels local to the site of spinal cord injury, ischemia occurs, resulting in the starving of healthy neural cells from oxygen. When this happens, voltage-dependent sodium channels of the healthy cells are abnormally activated, causing an increase in the sodium ion concentration within affected cells. The sodium-potassium pump is affected by ischemia, leading to reduced efflux of sodium. This increased sodium concentration in the cells leads the sodium-calcium pump to favor the influx of calcium ions, which further causes activation of calcium-dependent enzymes that adversely affect the structure and function of the cells in the area. Riluzole stops the process before the abnormal influx of sodium, effectively avoiding recruitment of the damaging calcium-dependent enzymes. Acute spinal cord injury also leads to excess extracellular glutamate, which can lead to damage or overactivate neural receptors, leading to cell death or damage. In addition to its role as sodium voltage-gated channel blocker, riluzole also modulates the release of glutamate. In effect, riluzole protects neural cells from damage resulting as a downstream effect of acute spinal cord injury. The practical effect of this has been far and wide, with both animal and human trials indicating efficacy in the areas of neuroprotection, motor recovery, and decrease in neuropathic pain. A combination treatment that helps to restore function below the site of acute spinal cord injury using a collection of research approaches is the eDura. The eDura is a device implanted directly onto the spinal cord that seeks to restore voluntary locomotion in spinal cord injury sufferers who experience paraplegia but have some intact neural tissue close to the site of injury. The device releases a cocktail of monoamine agonists, primarily serotonin and dopamine, and produces the electrical signals across the site of injury. With proper rehabilitation, the device facilitated voluntary movement in the previously paralyzed limbs, and after some time demonstrated an ability to promote extensive remodeling in the portion of existing neural circuitries close to the site of spinal cord injury. For long-term implantation, the device needed to match the mechanical properties of the spinal cord, so as not to shear the spinal cord or become dysfunctional due to its own damage. The device is nearly as flexible as living tissue and retains all necessary electronics to adequately provide neural stimulation at the site of spinal cord injury. The successful prototype of the device proved to be a silicon substrate with cracked gold electric conducting tracks on its surface, with electrodes made of silicon and platinum microbeads. Additionally, it has a fluidic microchannel, which allows for delivery of the pharmacological agent monoamine agonist combination to perform the necessary process. Whilst this treatment option is still some time away for acute spinal cord injury sufferers, there is immense hope that in the near future, incomplete spinal cord injury need not cause paraplegia. I'm Alexandra, and this is the latest for UTS News.